Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of citrullinemia, designed for general pediatricians. Citrullinemia is a urea cycle disorder that can present as a life-threatening neonatal emergency or as a milder late-onset condition. We will work through 14 carefully crafted clinical cases covering neonatal presentation, the underlying enzyme defect, the diagnostic amino acid profile, newborn screening, precipitating factors, acute and long-term management, nitrogen scavenger therapy, complications, liver transplantation, and the biochemical differentiation of urea cycle disorders. Let us begin. Case 1. A 2-day-old term male has progressive lethargy, poor feeding, and vomiting since 18 hours of age. On examination, there is hypotonia, an absent Moro reflex, and a bulging interior fontanelle. Laboratory highlights show ammonia of 720 micromoles per liter, a pH of 7.34 with no acidosis, glucose of 3.4 millimoles per liter, which is normal, and a white blood cell count of 9.2 times 10 to the third per microliter, also normal. What is the most likely diagnosis? Option A, citrullinemia type 1, classic form. Option B, neonatal bacterial sepsis. Option C, organic acidemia, such as methylmalonic acidemia. Option D, neonatal hepatitis with acute liver failure. The correct answer is option A, citrullinemia type 1, the classic form. The key clue is severe hyperammonemia with no acidosis and no ketosis. This combination points strongly to a urea cycle disorder. Symptoms begin only after the initial protein feeds, following a normal birth and a symptom-free interval. Ammonia rises rapidly above 500 micromoles per liter, producing severe neurological depression with hypotonia and absent reflexes. Plasma citrulline is dramatically elevated, typically between 800 and 5,000 micromoles per liter. This is the critical distinction. Sepsis and organic acidemias cause a metabolic acidosis, which is absent here. Case 2. A neonate has an ammonia level of 680 micromoles per liter. Plasma amino acids show citrulline above 2,000 micromoles per liter, argininosuccinate absent, and glutamine elevated. There is no acidosis. Which enzymatic deficiency causes this biochemical pattern? Option A, carbamoyl phosphate synthetase 1. Option B, ornithine transcarbamylase. Option C, argininosuccinate synthetase 1. Option D, argininosuccinate lyase. The correct answer is option C, argininosuccinate synthetase 1 deficiency. This enzyme normally combines citrulline with aspartate to form argininosuccinate. When it is blocked, citrulline accumulates massively and no argininosuccinate is produced. Compare this with the other defects. In carbamoyl phosphate synthetase 1 deficiency, citrulline is very low because it cannot even be synthesized. In ornithine transcarbamylase deficiency, which is X-linked, citrulline is also low, but urinary orotic acid is high. In argininosuccinate lyase deficiency, citrulline is only moderately raised and argininosuccinate is markedly elevated. The absent argininosuccinate with very high citrulline is what pinpoints argininosuccinate synthetase 1. Case 3. A 3-day-old female presents with ammonia of 890 micromoles per liter, lethargy, and hypotonia. Urine orotic acid is normal. The blood gas shows a pH of 7.36 with no acidosis. Plasma amino acids are ordered by tandem mass spectrometry. Which result is most characteristic of citrullinemia type 1? Option A, phenylalanine 1200 micromoles per liter, elevated, tyrosine normal. Option B, ornithine 450 micromoles per liter, elevated, homocitrulline present. Option C, methionine 850 micromoles per liter, elevated, succinyl acetone present. Option D, citrulline 3500 micromoles per liter, markedly elevated, argininosuccinate absent. The correct answer is option D, markedly elevated citrulline with absent argininosuccinate. Citrulline is normally only 10 to 45 micromoles per liter. In citrullinemia type 1, it rises to between 800 and 5,000 micromoles per liter. Because the argininosuccinate synthetase 1 block is complete, no argininosuccinate is produced, and this confirms the diagnosis. The other options describe entirely different disorders. Option A is phenylketonuria. Option B is hyperornithinemia, hyperammonemia, homocitrullinuria syndrome. Option C, with elevated methionine and succinyl acetone, is tyrosinemia type 1. Recognizing this specific citrulline pattern allows a rapid and definitive biochemical diagnosis. Case 4. A 36-hour-old asymptomatic male infant has an abnormal newborn screening result. The test used tandem mass spectrometry performed on a dried blood spot collected at 24 hours of age. Which marker is elevated on newborn screening tandem mass spectrometry, prompting investigation for citrullinemia type 1? Option A, propionyl carnitine markedly elevated with methylmalonyl carnitine present. Option B, citrulline markedly elevated above 100 micromoles per liter on dried blood spot, where normal is roughly 10 to 20. Option C, phenylalanine above 120 micromoles per liter with an elevated phenylalanine to tyrosine ratio. Option B, methionine elevated with positive succinyl acetone. The correct answer is option B, markedly elevated citrulline. Citrulline is the key marker on newborn screening tandem mass spectrometry. The normal range on a dried blood spot is roughly 10 to 20 micromoles per liter, and in citrullinemia type 1, values often exceed 200 to 500 micromoles per liter. A positive screen must trigger urgent confirmatory testing, plasma amino acids, plasma ammonia, and a clinical assessment. Remember that citrulline is also moderately elevated in citrullinemia type 2 and in argininosuccinate lyase deficiency, so confirmatory testing is essential. Citrullinemia type 1 is a core condition on the American College of Medical Genetics recommended uniform screening panel. Case 5. A 9-year-old girl with known citrullinemia type 1, well controlled on sodium benzoate and protein restriction, presents with vomiting, progressive confusion, and behavioral change over 24 hours. She had an upper respiratory tract infection 3 days ago. Her ammonia is 380 micromoles per liter, and pH is 7.32. What is the most common precipitating factor for acute hyperammonemic decompensation in a child with known citrullinemia type 1? Option A, intercurrent illness, such as infection, fever, or surgery, with catabolism and increased protein breakdown. Option B, dietary noncompliance, with excessive chocolate consumption. Option C, a missed dose of folic acid supplementation for 2 days. Option D, excessive exercise-induced muscle hypertrophy. The correct answer is option A, intercurrent illness and catabolism. Infection, fever, or surgery push the body into a catabolic state. Muscle protein is broken down, releasing a large nitrogen load. This load overwhelms the limited residual urea cycle capacity, and ammonia surges, leading to a hyperammonemic crisis. This is why every intercurrent illness is dangerous in these children. The sick day rule is essential. Increase calorie intake, temporarily reduce protein, escalate the nitrogen scavenger dose, and seek early medical attention. Families must be taught to recognize illness as the warning sign and to act before the child decompensates. Case 6. A 36-hour-old neonate is comatose and requires respiratory support. Ammonia is 950 micromoles per liter against a reference of below 110. Birth weight is 3.4 kilograms and intravenous access has been established. What is the most important initial pharmacological treatment for this hyperammonemic crisis? Option A, oral lactulose and dietary protein restriction alone. Option B, intravenous acyclovir and broad-spectrum antibiotics empirically. Option C, intravenous sodium benzoate plus sodium phenyl acetate plus intravenous arginine hydrochloride. Option D, intravenous sodium bicarbonate bolus followed by furosemide diuresis. The correct answer is option C, intravenous sodium benzoate, sodium phenyl acetate, and intravenous arginine hydrochloride. Sodium benzoate and sodium phenyl acetate are nitrogen scavengers. They remove 1 to 2 nitrogen atoms per molecule through urinary excretion, providing an alternative pathway for nitrogen disposal. Intravenous arginine hydrochloride is also essential because in citrullinemia type 1, the patient cannot synthesize arginine, and it is given at 2 to 4 milliequivalents per kilogram per day. At the same time, stop all protein intake for up to 24 to 48 hours and give a high-calorie glucose infusion to suppress catabolism. If ammonia is above 500 micromoles per liter or there is no response within 4 to 6 hours, start continuous renal replacement therapy or hemodialysis. The target is ammonia below 100. Case 7. A 35-year-old Japanese man presents with recurrent episodes of confusion and hyperammonemia with ammonia at 250 micromoles per liter. He strongly prefers meat, cheese, and beans, and actively avoids sweets and carbohydrates. He had neonatal cholestatic jaundice that resolved spontaneously. Liver biopsy shows fatty liver with periportal fibrosis. Plasma citrulline is 180 micromoles per liter. Which condition best explains this clinical picture? Option A, citrullinemia type 1 with late onset presentation. Option B, ornithine transcarbamylase deficiency, late onset. Option C, non-alcoholic steatohepatitis with hepatic encephalopathy. Option D, citrullinemia type 2, citrin deficiency, from an SLC25A13 mutation. The correct answer is option D, citrullinemia type 2, also called citrin deficiency. Citrin is the mitochondrial aspartate glutamate carrier, encoded by the SLC25A13 gene. It has three phenotypes that evolve over a lifetime: neonatal cholestasis, then childhood failure to thrive, then an adult neuropsychiatric crisis. The hallmark clue here is the instinctive carbohydrate aversion, with a preference for protein and fat. Citrulline is only moderately elevated, between 100 and 400 micromoles per liter, not the extreme values seen in type 1. This condition has an East Asian predominance. Treatment is a low-carbohydrate diet, medium-chain triglyceride oil, and sodium pyruvate, while liver transplantation is curative. Case 8. A 4-year-old girl with citrullinemia type 1 is metabolically stable on her medications. Her metabolic dietitian is counseling the family on long-term nutrition management. What is the cornerstone of long-term dietary management in citrullinemia type 1? Option A, protein restriction, around 1.2 to 2 grams per kilogram per day, with essential amino acid supplementation and avoidance of prolonged fasting. Option B, a complete protein-free diet, with all protein replaced by essential amino acid formulas only. Option C, a high-protein, low-carbohydrate ketogenic diet to reduce ammonia generation. Option D, an unrestricted diet with an increased sodium benzoate dose to compensate. The correct answer is option A, protein restriction with supplementation. Natural protein is restricted to roughly 1.2 to 2 grams per kilogram per day. This limits the ammonia load while still preserving enough protein for normal growth. An essential amino acid formula then fills the remaining nutritional gaps safely. Oral arginine supplementation is essential because citrullinemia type 1 blocks the body's own arginine synthesis. Prolonged fasting must be avoided because overnight catabolism triggers an ammonia surge. Frequent meals and a bedtime snack protect against this. A protein-free diet is wrong and dangerous as it causes its own catabolism. Ongoing monitoring includes ammonia, plasma amino acids, growth, and albumin. Case 9. A 7-year-old boy with citrullinemia type 1 takes oral sodium benzoate and sodium phenylbutyrate daily. His mother asks how these medications reduce ammonia levels. How does sodium phenylbutyrate, also known as buphenyl, reduce ammonia? Option A, it blocks hepatic amino acid deamination directly. Option B, it stimulates residual argininosuccinate synthetase 1 enzyme activity. Option C, it is converted to phenylacetate, which conjugates glutamine, leading to urinary nitrogen excretion. Option D, it chelates ammonia in the gut lumen. The correct answer is option C. Sodium phenylbutyrate is an oral prodrug. The liver oxidizes it to phenylacetate. Phenylacetate then conjugates with glutamine to form phenylacetylglutamine, which is excreted in the urine, removing 2 nitrogen atoms per molecule. Sodium benzoate works in a parallel way. It conjugates with glycine to form hippurate, which is excreted in the urine, removing 1 nitrogen atom per molecule. Because each agent removes nitrogen by a different route, combined therapy achieves maximum nitrogen removal. There is also a liquid prodrug formulation, glycerol phenylbutyrate, which offers better gastrointestinal tolerability. Case 10. A 5-year-old boy with citrullinemia type 1 who is non-compliant with diet and medications presents for annual review. His ammonia is chronically elevated between 150 and 300 micromoles per liter. Which combination of findings is most likely in this child? Option A, facial dysmorphia, hepatosplenomegaly, and skeletal dysplasia. Option B, growth failure, microcephaly, intellectual disability, hepatomegaly, and behavioral symptoms. Option C, blistering skin lesions, alopecia, and lactic acidosis. Option D, cherry red spot, coarse facial features, and corneal clouding. The correct answer is option B, growth failure, microcephaly, intellectual disability, hepatomegaly, and behavioral symptoms. Chronic hyperammonemia causes astrocyte swelling and ongoing brain injury over time. This produces microcephaly from arrested brain growth, intellectual disability, and attention deficit-like behavioral symptoms. Hepatomegaly develops from glycogen accumulation, and growth failure results from the combination of protein restriction and chronic metabolic stress. The other options point elsewhere. Dysmorphia and skeletal changes suggest lysosomal storage disorders. Skin lesions and alopecia suggest biotinidase deficiency. And a cherry red spot suggests a gangliosidosis. None of these belong to citrullinemia. Case 11. The family of a 2-year-old girl newly diagnosed with citrullinemia type 1 asks about long-term complications to watch for, even with good metabolic control. Which statement best describes the long-term complications of citrullinemia type 1, even with optimal management? Option A, cardiac cardiomyopathy and arrhythmias are the leading cause of death in well-treated patients. Option B, chronic renal failure due to tubular citrulline deposition is the primary complication. Option C, recurrent pancreatitis is the most significant gastrointestinal complication requiring routine monitoring. Option D, neurodevelopmental delay, intellectual disability, and episodes of acute metabolic decompensation remain significant risks despite treatment. The correct answer is option D. Even with optimal management, neurodevelopmental delay and the risk of acute decompensation persist. Each hyperammonic episode causes cumulative, irreversible brain injury. Roughly 50 to 70% of citrullinemia type 1 patients have some degree of intellectual disability or learning difficulties. The best neurological outcome comes from early diagnosis through newborn screening combined with strict, lifelong metabolic control. The other options describe complications that are not characteristic of this disorder. The central long-term threat is to the brain. Case 12. A 3-year-old boy with citrullinemia type 1 has had 3 hyperammonemic crises requiring hospitalization in the past 12 months, despite maximal medical therapy and excellent dietary compliance. Neurodevelopmental assessment reveals mild intellectual disability. Which statement regarding liver transplantation in citrullinemia type 1 is most accurate? Option A. Liver transplantation is curative for hyperammonemia because the argininosuccinate synthetase 1 enzyme is replaced in the donor liver, and dietary protein restriction can be significantly liberalized after transplant. Option B. Liver transplantation corrects both the metabolic defect and pre-existing neurological damage, fully reversing intellectual disability. Option C. Liver transplantation is contraindicated in children under 5 years with citrullinemia type 1. Option D. After liver transplantation, nitrogen scavenger medications must be continued lifelong at full doses. The correct answer is option A. The donor liver supplies functioning argininosuccinate synthetase 1 enzyme, so ammonia and citrulline normalize after transplant. Dietary protein restriction can then be significantly liberalized, and nitrogen scavenger medications can be discontinued once liver function is restored. However, there is a critical caveat. Transplantation corrects the metabolism, but it does not reverse pre-existing neurological damage. Any intellectual disability already present is permanent. This is exactly why early diagnosis and prevention of crises matter so much, and why transplantation should be considered before repeated decompensations cause further irreversible injury. Case 13. Compare 3 neonates. Neonate A has ammonia of 750 micromoles per liter, very low plasma citrulline, and elevated urine orotic acid. Neonate B has ammonia of 680 micromoles per liter, very low plasma citrulline, and normal or low urine orotic acid. Neonate C has ammonia of 920 micromoles per liter, plasma citrulline of 2,800 micromoles per liter, markedly elevated, and absent argininosuccinate. Which diagnosis correctly matches neonate C? Option A, ornithine transcarbamylase deficiency. Option B, carbamoyl phosphate synthetase 1 deficiency. Option C, citrullinemia type 1, argininosuccinate synthetase 1 deficiency. Option D, argininosuccinic aciduria, argininosuccinate lyase deficiency. The correct answer is option C, citrullinemia type 1, argininosuccinate synthetase 1 deficiency. Neonate C has very high citrulline with no argininosuccinate synthetase 1 deficiency. Now look at the others. Neonate A has low citrulline with high orotic acid, which points to ornithine transcarbamylase deficiency. Neonate B has low citrulline with normal orotic acid, which points to carbamoyl phosphate synthetase 1 deficiency. Arginosuccinate lyase deficiency would instead show moderately elevated citrulline with markedly elevated arginosuccinate. So the two questions to ask are, is citrulline high or low, and is arginosuccinate present or absent? Those two answers separate every urea cycle disorder. Case 14. A 6-year-old girl with citrullinemia type 1 is stable on sodium phenylbutyrate, oral arginine, and a protein-restricted diet at 1.5 grams per kilogram per day. She has had no hospitalizations in 2 years, and you are planning her routine monitoring visit. Which set of monitoring parameters is most appropriate for routine long-term follow-up? Option A, quarterly plasma ammonia, plasma amino acids every 3 to 6 months, annual neurodevelopmental assessment, growth monitoring, and liver function tests. Option B, monthly brain imaging, weekly plasma amino acids, and daily ammonia home testing. Option C, quarterly liver biopsy, 6-monthly endoscopy, and annual cardiac catheterization. Option B, annual renal biopsy, quarterly echocardiogram, and monthly bone densitometry. The correct answer is option A. Routine follow-up is built around plasma ammonia checked at every visit and at minimum quarterly, with a target below 100 micromoles per liter, and any illness prompting an urgent check. Plasma amino acids are measured every 3 to 6 months, aiming for citrulline 50 to 150, arginine 50 to 200, and glutamine below 800 micromoles per liter. Growth and nutrition, including height, weight, head circumference, and albumin, are assessed at every visit. Neurodevelopmental assessment and liver function with ultrasound are done annually. The other options rely on invasive or excessive testing. Brain imaging is reserved for neurological regression, not routine use. And every intercurrent illness should trigger an urgent ammonia check and activation of the sick day plan. Before we close, I want to tell you about our community on Patreon called Pediatric Case Review. This community brings all of our videos together in one place, systematically arranged by body system, so you can study each topic in a structured and focused way. In addition, all of the presentations used in the videos are available as images, so you can read, review, and practice every question at your own pace, even offline. It is a growing community of pediatric learners preparing together. If you would like details and to learn how to subscribe, please leave a comment below this video, and we will message you directly. Let us bring this together with 6 key takeaways every pediatrician must remember about citrullinemia. First, think urea cycle disorder early. A term neonate with hyperammonemia and no acidosis after feeding onset has a urea cycle disorder until proven otherwise. Second, citrulline is diagnostic. A citrulline above 1,000 micromoles per liter confirms citrullinemia type 1. Third, act without delay. Ammonia above 500 means intravenous nitrogen scavengers, intravenous arginine, and renal replacement therapy now, because every hour adds brain damage. Fourth, newborn screening works and catches the disease before crisis. Fifth, transplantation corrects the metabolism, but pre-existing brain injury remains. And sixth, lifelong vigilance is required, with regular monitoring and sick day plans even in well-controlled patients. Thank you for joining this case-based review of citrullinemia. We hope it strengthens your clinical approach to this important group of disorders. Please remember that these lectures are for educational purposes only and do not constitute medical advice. Always consult current guidelines and specialists for clinical decisions. If you found this lecture helpful, please follow the channel for more informative case-based pediatric presentations. If you have any questions, leave them in the comments below and share this with your colleagues. Until next time, keep learning and keep caring for your patients.